is one of our chief residents in child neurology, to do some discussion this morning on some of her work in long-term neurodevelopmental outcomes after ECMO in children. And appreciate our discussion this morning, Dr. Thamann.
Awesome. Thank you for the introduction. So thank you for having me. I'm really excited to tell you about this. It's mostly going to be kind of a dive into the literature and what we do know about long-term neurodevelopmental outcomes after ECMO in pediatric patients, and then talk a little bit about our study that's gotten started. So really, there we go. So this all came about because on one of those very long nights in the pediatric ICU a few years ago as a PGY2, we had this patient that everyone in the ICU was really excited to see. So he was a 16-year-old boy who was previously healthy and just had fulminant respiratory failure months prior and ended up going on ECMO. I honestly can't remember the details of kind of why and ultimately what they thought his problem ended up being, but he went on ECMO for a week or so, ended up ultimately getting better and had gotten a trach and was bad the night I was on, came back as a scheduled admission to get his trach removed. So everyone was so excited to see him because he had done so well. And so I hear about this guy, and I'm seeing these other patients on ECMO and how sick they are and how sick they look, and thinking, oh my gosh, can anyone survive? And more importantly, can anyone thrive after being this sick? And here he was, standing, brushing his teeth, talking to all the nurse practitioners and attendings who had taken care of him prior, who he didn't really remember, right? Because he was so sick. But I don't know, that got me thinking, how do some people do well and clearly others really don't on ECMO? So that got me thinking about this. So what do we know? That's going to be the bulk of this talk, is trying to tease out what we do know about these outcomes after ECMO. So we know that ECMO is a really high-risk clinical situation, right? It's kind of one of the last things you can do to try to help someone survive. Mortality is high. These patients are really sick. ECMO is not an easy thing. It's not an easy fix. Mortality is 35 to 45%, depending on the paper that you read. This is easily measurable, right? This is kind of a yes or no question. Do they survive? Did they not? This is very objective data. Easy to kind of figure out. We also know that these kids are at increased risk for seizure, stroke, neurologic injury, or complication in general. Wide variation on what the papers say for risk of these things, but anywhere from 15 up to 40% or higher, depending on the paper that you look at. This paper looked at patients who had undergone ECMO and their risk of trying to tease out what their risk of neurologic injury was and see if there's any kind of variables that they could see that would be more common in CNS injury versus not. They found that about 11% of people ended up being brain dead. About 7% of their population ended up having a stroke, and about an ischemic stroke, and about another 7% ended up having a hemorrhagic stroke. Cardiac disease had a higher incidence of these issues, so if you went on ECMO for cardiac disease, and we'll see this pattern emerge, that congenital heart disease is a risk factor for just doing more poorly in general in almost all areas. But they were at higher risk for CNS injury, and mortality is higher in patients with CNS injury. Also looked at things like we could predict based on basically how bad their blood gas was on will they have CNS injury or are they at higher risk for CNS injury. And this paper did find that that maybe a lower blood gas can be predictive of CNS injury, pulmonary hemorrhage, need for dialysis, and how long CPR went during ECMO or other kind of risk factors. And again, a lot of this kind of stands to reason if you logic your way through, but the data does support that people with neurologic injury, again, hemorrhage, infarct, this increases mortality, this increases morbidity, and decreases quality of life. Again, that's logical, right? If you end up with a huge stroke while you're on ECMO, you're going to have more morbidity, you're going to have a longer recovery, you're going to have probably at least at risk for more significant, very long-term deficits. Again, this is kind of a yes or no question, right? I mean, it's more difficult than survival, but this is like, is neurologic injury present? Is it not? We can look, was stroke present? Was it not? Was hemorrhage present? Was it not? Were seizures present? Were they not? So this is a little easier to measure. It's more objective. So we know that critically ill patients are at higher risk of neurologic injury in general, but there is some data to support that ECMO adds to this risk as an independent risk factor. And that's the question, right? Are these patients sick because they're sick, or are they sick and injured because they were on ECMO specifically? And that's where the hard part comes in. So this paper from 2013 looked at intelligence in patients who had been on ECMO versus not. This was a very specific population of patients with congenital diaphragmatic hernia. Again, very small sample sizes, another theme that you're going to see throughout this, because numbers are just small, thank goodness, I guess, but numbers are just small, and basically you want to see larger proportion of this bar, basically. You want to see that closer to the 100%, so kind of a normal intelligence range. In the ECMO group, you can see you have a much larger percentage of this black bar and even this white bar, so lower intelligence. And compared to the non-ECMO group, you have a higher proportion of people doing better on kind of your intelligence scale. Again, implying that in this population of trying to compare apples to apples, right? So these patients that had the same problem were all critically ill, because no matter what, with a congenital diaphragmatic hernia, you're going to be ill for a while. Trying to tease out ECMO versus non-ECMO, how these scales did. We also have evidence from this 2019 paper that did look at more specific developmental outcomes after ECMO, that patients do worse on the Bayley. The Bayley is a very common, decently comprehensive developmental scale. We use it a lot, for example, in our Nicu follow-up, but just to keep track of how these babies are doing developmentally. This paper did the Bayley. Again, pretty extensive, looks at different domains of development, cognitive, language, motor. And this showed that patients who had been on ECMO did poorer on these scales. Again, it kind of stands to reason, right, that these patients might do worse after being so sick that they're on ECMO, or being on ECMO in particular. These patients do worse on the Bayley in all three domains compared to their peers. And this again tried to match ECMO versus non-ECMO, and showed that the ECMO group did worse. This is retrospective. Another paper from 2020 looked at brain volumes of ECMO patients versus non-ECMO patients. So our blue line is patients who did not have ECMO during their course. The green line is that patients that did. Again, these are trying to match subjects who had, again, similar problems. This is in a congenital heart disease population. So it showed that, again, this green line, these patients who were on ECMO compared to the patients who were not, this blue line did worse. Their brain volumes were smaller compared to the patients who did not have ECMO. Interestingly, they took that a step further and said, hey, what about patients that had multiple ECMO runs? And that is not uncommon in our heart babies. We just had one this week that was a child with congenital heart disease that last week had their second run of ECMO, and that's crazy to think about, right? But those patients did even worse. They looked at if you look at this red line, that's way lower. Their brain volumes were even lower when compared to this green line, patients who had one ECMO run versus this blue line, no ECMO. And they did significantly worse, right? Those brain volumes are so small. We also know that after ECMO, patients probably have an increased risk of neurodevelopmental issues. Again, that stands to logic, and that's what we're trying to see if the data stands up to the logic that these patients probably don't do as well in the long term. This paper from 2013 and was cardiac patients who went on ECMO for a cardiac indication only. It was retrospective, a 5-year study. It looked at the PCPC, or the Pediatric Cerebral Performance category, which I'll tell you more about later. in the POPC, which is a similar scale to that. Just kind of overall, it's a 1 through 6 scale. These look at just kind of overall performance in life. It's very kind of easy to tell. Again, you'll see that the actual scale later, but it showed that a large proportion of people ended up having moderate disability or severe disability in both of these scales, depending on how many days they were on ECMO. Another risk factor for doing more poorly on these developmental outcomes, or on these scales at least, was duration of CPR longer than 50 minutes. Again, stands to reason if you're down for longer. And people who had an infarct or hemorrhage during that time ended up with a worse worse performance on these scales than if they did not have an infarct and hemorrhage. Again, stands to reason. Another retrospective study from 2017 looked at patients with Ct Head Abnormalities. And again, just thinking about it, if you see anything on Ct Head, right, our less specific mode of imaging, head imaging, they're probably going to do worse because you can see an injury that they have there. So that showed that it compared to patients with a normal head CT or no head CT, which is kind of an important thing to note in this study, right? If you don't look for it, you can't find it, but that does imply that these kids didn't have necessarily a reason that they were going to get head CT. And again, this is retrospective, so we couldn't control that. But patients who had an infarct on CT or a hemorrhage on CT did worse. Their scales, these higher outcome or worse outcomes on these scales correlated with patients, were more common in patients who had an infarct or hemorrhage on CT. 2018 study was again retrospective, looked at the aspect score and in patients that did have a CT head, and said that this could be predictive of a poor neurologic outcome as well. So again, this is all kind of obvious what I've said so far, as patients with stroke, hemorrhage, etc. are at higher risk of neurodevelopmental issues, and patients on ECMO are at higher risk for stroke, hemorrhage, etc. Some of this is less obvious. What about seizures? So if a patient has a seizure, do they do worse? There were a few studies that have looked at least at the incidence of seizure and kind of trying to correlate that with injury, and therefore asking, do they do worse or not? So all three of these studies showed about 20% of patients on ECMO ended up having seizures, which is pretty high, and I think that we see that a lot anecdotally. We see seizures in these patients a lot. And it stands to reason that more of the patients that had seizure were due to injury on CT head. So the patients that had a hemorrhage, had an infarct, were more likely to have seizure, 78% of them, compared to 44% of the patients who did not have injury on their CT head. So patients with neurologic injury that we can see are more likely to have seizures. Just another paper saying the similar thing, that patients who had seizures compared to patients who did not have seizures were more likely to, again, score in the more severe range on this pediatric cerebral performance category, or this kind of scale of how they do clinically. So it's probably an indicator for poorer outcome. Is that an independent risk factor? Is it just seizure, versus is it because the same kids that have the seizures are the same kids that have neurologic injury? I don't think we've teased that out. I think it could definitely just be because they have neurologic injury, and we can't say for certain that this is an independent risk factor, seizure that is. And more of the same again, if they have stroke or hemorrhage, they're more likely to seize. They're also less likely to survive. So patients who had a seizure were less likely to survive. Again, same thing, can't say that's an independent risk factor, but an important thing to think about. This is a really interesting paper if anyone has time to read it. can we predict who will do better or do worse? And that's like the long-term goal of anything we do in this arena is, can we improve our performance on ECMO? Can we improve how we do ECMO? Can we improve what we do during their courses in neurology in the ICU setting to see if they can do better? So the first step of that is trying to see if, hey, can we predict reasons that people might do better or worse? So that's one thing that this paper, I think, found more so than people doing better. This is kind of all the figures are really interesting. This is kind of their culmination at the end of this paper, is they looked at all these areas under the curve and all these risk factors to try to see, hey, can any of these be kind of predictive of how people do? And they used a different kind of scale than I've used, but it's a similar kind of scale out of 16, or a scale that if you do over 16, that implies a more severe functional impairment than under 16. So they're looking at what increases odds of having a score that is poor. So their functional status at admission, if they have low functional status at admission, and again, it makes sense that they would be at higher risk of a low functional score at discharge. So that makes perfect sense, right? That's not like mind-boggling. Single ventricle physiology, so kids who have severe congenital heart disease, they did poor with their functional outcomes. Makes sense, right? These kids before their ECMO run, after their ECMO run, are very, very sick, have a lot of issues. ECMO duration was a risk factor. Longer ECMO duration basically was a risk factor for doing more poorly on this, on functional score at the end of this. That's at discharge, and then they also kind of tease things out to look at 6 months down the road, because that's the question too. If you survive, are you thriving? How are you doing later on in life? Similar thing, functional status on admission makes sense. What you were like before, that's kind of what you're trying to get back to, right? Your baseline, but kids with single ventral physiology or severe cardiac disease or prolonged ECMO duration had risk or at risk for doing worse on these functional scales. So, as you can see, pretty much everything I've shared so far has been retrospective. You know, it's not difficult to do retrospectively with data that is collected anyways. Again, a lot of these kids are going to get imaging of some kind, but not all of them. But it's a limitation. You know, it is retrospective. We can't control for everything. There's not much prospective data at all. There is one paper from 2017 that is prospective, but kind of neurodevelopmental outcomes were not a primary outcome measure. It was a mixed population of neonates, infants, and children. So we also have a lot of heterogeneity in this group, children less than 19 overall, and looked at functional status scales, kind of similar to what I've mentioned. So it found that patients who ended up with a neurologic disease during or at the end, during their course, their ECMO course at some point, did worse. And prospectively, though, that's the difference between this and previous papers I've mentioned. So they did worse on these scales compared to their survivors, or to other survivors, sorry. And again, cardiac indication implying that congenital heart disease, there are other cardiac indications, of course, but the bulk of this population is going to be your congenital heart disease kids. They did worse as well. Their functional status was worse at the end. ICU length of stay was also increased, also basically a risk factor for doing more poorly. Again, makes sense. If you stay in the ICU for longer, you're probably sicker, which means that your function might be poorer than your peers. Another prospective study in 2015 was a prospective over 10 years, which is awesome. This is only in congenital heart disease kids. And for reference, here's a normal IQ kind of bell curve. The average is supposed to sit here at 100. So you can see this IQ is pretty significantly skewed to the left. Their peak is at the 70 to 85 range as opposed to the 100 range. So that's pretty significant, right? Like, this is, again, a particular population. This is just our cardiac kids. But that's a significant decrease in IQ compared to their peers. 2019, we had a paper that compared Vineland scores among ECMO survivors. Vineland is just another developmental profile, again, a decently comprehensive one that looked in different domains. And it divided these, I thought this was good. So it tried to look at a population of kids that had been on ECMO for a variety of reasons, to cardiac and congenital heart, versus just a kid who gets sick for any reason. And it divided them up into those with negative neuroimaging, so patients that we could not see an infarct, hemorrhage, et cetera, on imaging, compared to those with normal neuroimaging findings. So no, like, noted large, at least, neurologic injury. So the findings were not significant, which is very important to note, obviously. But you can see a trend here. So on the left of each one of these bars is normal neuroimaging compared to those with abnormal neuroimaging, and looking at basically different domains, different scales, different measures of functional status. Overall, you can see a trend here that patients with abnormal neuroimaging, their averages bars tend to be kind of lower. The bar on the right tends to be lower than the one on the left in almost all of these domains. This last picture in particular, the pediatric stroke outcome measure, is actually a measure of neurologic exam, which I'll talk about later, but it basically takes your exam and applies an objective number to it. So if you're higher, then you have a more abnormal neuro exam. So the trend is the opposite in this. So those with normal neuro injury, more of them had a less severe, less abnormal or more normal neurologic exam compared to those with some kind of abnormal imaging. So again, some kind of injury that you can see on CT or MRI. So that's pretty much it. I have read on this topic extensively. There's such little prospective data. There's really not a lot out there, and I've shown you most of what I could find. Also worth noting that very little of it looks at more than kind of basic functions. So a lot of these papers, the ones I've mentioned, are great that have really done a Vineland or looked at least retrospectively using a Bailey at two kind of more comprehensive neurodevelopmental measures, with looking at different developmental domains, but lots of them are more these kind of generalities. These how's their overall performance in life, what's their IQ, those kinds of things. We can also tell from this, especially that last paper, that there's such a wide range of how survivors do. Some will miraculously, semi-miraculously, like this kid I mentioned at the very beginning, be standing and talking and walking and doing fine and continue back to their baseline. And some die, first of all, but some who don't die are just devastated and do super, super poorly. Patients with neurologic injury, we know they're going to do worse, but what about these patients who don't have a known neurologic complication? So the patients that we with neurology don't end up seeing, the patient that doesn't have a stroke, doesn't have a huge hemorrhage on CT, doesn't have concern for seizures, so we never see them. How are they doing? We know they'll do a little bit better, but how are they doing, in these more specific developmental domains? Are they really, truly back to their baseline? Or are they just able to do their ADLs, so we're saying they're okay, So there's a lot of weaknesses of the current literature available, so we have very small sample sizes. This is very hard to get around. By its nature, this is qualitative data, so different than the things I mentioned at the very beginning of this talk, so different than just survival. Did they survive, did they not, kind of binary. Different than, did they have a stroke, did they not, again, kind of binary. Looking at more specific neurodevelopmental outcomes is by its nature pretty qualitative data, so it's more difficult to collect in some ways. It's can be more cumbersome. It's more difficult to kind of analyze for that reason. There's a lack in the prospective data. There's a lack of non-congenital heart disease data, so a lot of the data we do have is in a pretty specific population. Which numbers-wise, it's worth mentioning, is most of the pediatric patients that go on ECMO. It's a huge proportion of them. So we already have small sample sizes with all the kids who go on ECMO. It's even smaller if you don't look at the cardiac kids. So that's a very particular group of people. Very wide age ranges. If you group by age, if you try to tease out, hey, how do the babies do compared to how does a healthy teenager do, then your sample sizes get even smaller. So what can you do about that? It's just a lot of heterogeneity. The overwhelming majority of these studies are retrospective, which is just the nature of things. So that's kind of the weaknesses of the current literature, right? We have some, we can kind of draw some conclusions, and we know that these kids are at risk for a neurologic injury. We think that these kids all do worse developmentally, but we don't have a ton of prospective data. So what are other folks doing in terms of following these kids going forward after a prolonged ICU course, after an Ecma course? Knowing this general risk of doing more poorly in these things, does anyone else do kind of a specific follow-up program? We have a very robust NICU follow-up program for any baby that was in the NICU, first of all, and the NICU does their follow-up, but we in Neurology follow them along as well in the NICU, kind of embedded in this multidisciplinary clinic for kids that we see in the NICU. There's not really a PICU follow-up system, and that's harder to do, and most institutions don't have like a similar PICU follow-up system. Does anyone do post-ECMO specific follow-up? Of course, these kids are going to see a variety of specialties depending on their reason for going on ECMO, but is there anyone doing like a specific post-ECMO clinic? So this paper from 2018 looked at that and basically found that only very few ECMO centers in the world provide like a comprehensive multidisciplinary follow-up from the time of discharge. So again, they're of course seeing specialists and of course getting follow-up with other people and us if we've seen them, but there's very, very few centers looking at this kind of more intensive multidisciplinary follow-up. Interestingly, this is a little blurb from this paper, and that neurodevelopmental problems in one clinic in the UK were found in 30% of patients, and some of the patients that did not follow up in their particular clinic. So there are particular recommendations that I did not realize until kind of digging in this year, really looking at this data. There are actual specific recommendations from ELSO, which is kind of the pediatric, or like the ECMO, they're the ECMO people, the ECMO national kind of organization that puts out recommendations for ECMO in general. And they have recommendations on follow-up and how to kind of stratify these patients and what kinds of things that they should be, that should be followed. So to break this down, I hope we can see a little better, but it's hard to read no matter what I did. So pre-ECMO, they're saying that we should be identifying risk factors and already trying to see what kind of things they should, what kind of studies they need, what kind of things that they should get once ECMO, while they're on ECMO or while they're in the hospital. So, the pre-ECMO is pretty standard. You're getting a normal history. We'll already know, if we're consulted coming in kind of in the ECMO course, a lot of this data has already been asked, right? Do they have a history of cardiac arrest? Do they have a history of seizures? What kind of patient are we talking about here? While they're on ECMO, ELSO is saying that we should consider neuro monitoring, consider looking at EEG in these patients. It doesn't really say how long. Looking at neurologic exams, again, sometimes if we do it, of course, do a very extensive neurologic exam, but sometimes we're relying on our ICU colleagues. What are the details of their cardiac arrest and reasons for going on ECMO? Any neuroimaging while they're on ECMO, which is very, very difficult to obtain, but sometimes there can be a Ct Head while they're on ECMO. And then looking at Neuro Protection. So in the ICU, the pediatric ICU, we don't really do full body cooling for HIE. That's a whole other discussion, but the studies did not stand up to support cooling for cardiac after arrest. But basically, you're looking at normothermia, controlling what you can control in terms of neuro protection. So trying to get things as normal as possible metabolically, normal temperature, those kinds of things. And then post-ECMO, they again have this list of recommendations that I don't know that I don't know that a lot of institutions look at. So they are saying that post-ECMO in the hospital, the kid should have a neurologic evaluation. They should have a plan for ongoing care. That stands to reason regardless. They should have a plan for a neurodevelopmental assessment that might involve physical therapy, occupational therapy. A lot of these kids will go to rehab. So again, that happens kind of automatically in a lot of these kids, but not all of them. Really important one, a request or appointment for audiology assessment. That's kind of beyond the scope of this talk, but kids on ECMO are at risk for hearing issues going forward. So all of them should have an audiology screen or assessment outpatient after their ECMO course. This paper is saying that all of them should get neuroimaging, ideally an MRI of the brain. I love this, right? We could do so much more. We could know so much more study-wise, even retrospectively, if all of them had an MRI and not just a CT. A lot of these kids will end up getting a CT, but some of them that we don't see and that do okay don't never end up getting an MRI, or at least not for quite some time. They should get nutritional assessment and advice. They should have a plan for psychosocial support for the family and family education. In this paper, these recommendations are saying that you should already be educating the family about follow-up and then giving disease-specific follow-up as well, of course, based on the problems that they've had. Longitudinally, again, this is mostly kind of disease-specific care, but this is recommending a neurodevelopmental assessment guided by either the neonatologist if we're in the Nicu setting, or a general pediatrician or developmental pediatrician. Almost all general pediatricians are going to do developmental screening in all their patients at some point, but these are short kind of, again, screeners in the purest sense of the word. They're trying to capture which kids they need to refer for more specific testing. And I think that, we don't know, we don't have the data to support this, but the thought would be that maybe these kids automatically should get much more intensive neurodevelopmental kind of visit and assessment. And then kind of looking at them long term, they're saying very vaguely we should help them grow into their deficits and work with the deficits that remain, which they should work on memory and executive functioning and doing well in school. That gets really vague, right? How? We don't really know, but if they're getting intensive neurodevelopmental assessments, then that can maybe help guide some of these things, because you'll find them. You don't find things unless you look for things. So long term, as I've mentioned, the idea is to try to see how kids, have kids on ECMO, see how they do, see if there's any predictors of people who will do better or worse, and then improve care, improve the ECMO course itself. So this paper just kind of looks at that kind of chain of events. This is another kind of flow paper that looked at what people are doing in terms of post-ECMO follow-up, and again, found that most people are just doing kind of disease-specific follow-up long-term, and in kids that did not have neurologic comorbidities or underlying diseases, it's just kind of various domains of follow-up, so we don't really know what that means. So this paper called for a more uniform follow-up system and said that there's such a wide variety in what centers do. We don't know that these kids are being followed appropriately and getting the therapies they need for things that are not as obvious, like not walking, that's pretty obvious, but these more specific executive function things, unless you look for some, you won't be able to define them. So why do we care about this? Why do we want to know more? We want to know what we don't know. We want to add to practice to evidence-based medicine. We want to know how these kids do. And we want patients to survive and thrive. Like, that's our job, right? We want patients to do better, and we want to learn how to make them do better, and not just survive, not just that binary yes or no, but like do well in their course and not be neurologically devastated, and get them up to their full potential in terms of their neurodevelopment. And then, like I've alluded to, we want to know are there things in their Ecma course that can lead to better or worse outcomes. Seizures as an independent risk factor, does that lead to poorer outcomes? And then are there things we can control? So seizures is a great example. Like, if seizures are an independent risk factor outside of significant neurologic injury that we can see pretty easily, should all of these kids get some kind of neuromonitoring? Most of them do, just by the nature of being paralyzed and whatnot, but should all of them get? That's just an easy example, but are there more things that we can control within the ECMO course to try to better outcomes? So what are we doing about this? So our current follow-up system in our ICU system, and neurology specifically within that, is essentially as needed. So of course we'll get consulted on a lot of these kids, but not all. And the ones we get consulted on, we always say, we'll follow them up outpatient. A lot of them are in the hospital for a really long time, so sometimes that gets lost in the shuffle, I think, quite frankly. We'll see them multiple times in the hospital if needed. And we're, at this point, starting to investigate things for ourselves. So this is where our study comes in. So we have a study entitled Long-Term Neurodevelopmental Outcomes After ECMO in Pediatric Patients. The PI is Dr. Lakodia. We have two awesome pediatric ICU doctors that are also helping us with this study, Dr. Havlin and Dr. Furlong-Dillard. And then have the help of Dr. Peary, of course, and then Dr. Calvary, who is an awesome neuropsychologist who has agreed to help me in these screeners that you'll see. So we tried to see, hey, let's look at the weaknesses of the study we have so far. I keep saying over and over again that our literature is not great, but what are the weaknesses, and is there anything that we can at least try to do about it to get more specific outcomes? Small sample sizes are what they are. It's really hard. Our center does, I think, 20 to 25 is the final number, or 15 to 20 patients, ECMO runs on patients a year. And we're a pretty big center, right? Especially from a cardiac congenital heart disease standpoint. So I don't know what we can do about that. By its nature, as I mentioned, this data is qualitative. We can try to make things as quantitative as we can by using scales and outcome measures that can give us a number to try to make this data as objective as possible. There's a lack of non-congenital heart disease data, so let's include everyone. Let's look at the kids with heart issues and long-term heart issues, but let's also look at healthy kids who end up on ECMO for whatever reason. The wide age ranges, if we group by age, we have even smaller numbers. That's kind of the nature of pediatric research in general. Pediatrics covers from age 0 or minus, minus however many weeks, all the way up to age 18. And that's just kind of the nature of things. I don't know that we can tease that out with such small sample sizes. The overwhelming majority of these papers are retrospective, so let's go prospective. Let's enroll patients and look at them going forward and follow them rather than looking backwards and only having the data that we have. Let's go prospective, and then we can control the data that we collect. So in short, we are enrolling patients on ECMO and following their development and functional status going forward. This includes chart review, a physical exam, neurologic exam, developmental screening, and then some social screening as well. So we'll dive into this a little bit more specifically, but basically within 48 hours, we're going to sign consents with the family if they agree to be enrolled in the study. We're going to review the protocol with them and likely go ahead and do visit 1, which I'll tell you about in a second. I can say now, having been doing this year, I've only had essentially one patient say no, and there was kind of a lack of understanding. I think there was a language barrier, so I think that just made things really difficult. Everyone, once you have time and can really kind of sit down and explain that this doesn't change their course, we're not, parents get really nervous if we're doing things like testing a new drug or whatever. This doesn't stop there, or doesn't change their care at all. So most parents, once they understand that, are like, oh, of course, yeah, collect whatever data you want. And some parents like that, like knowing that we're going to be looking at the development of their child also. Again, some kids would have this anyways, but they like knowing that someone's keeping an eye on. So our inclusion criteria is patients admitted to the pediatric or cardiac ICU who undergo ECMO for any indication. Again, this includes patients with known congenital heart disease and patients without. At the time of the inclusion in the study, we want them to be at least corrected for 36 weeks gestation. So they could have been born prematurely prior, but at the time of enrollment need to be at least corrected for 36 weeks, and all the way up to 18 years old. Exclusion criteria is patients less than 36 weeks corrected gestation, older than 18 years of age, which those patients do come in our hospital sometimes. Patients who die during their hospital course will be included from analysis, so I'll get to this, but that does happen, of course. I noted to you a 35 to 45% mortality risk with ECMO in general, so of course some of these patients are unfortunately not going to make it. And if we enroll within 48 hours of ECMO initiation, we don't know that, who's going to make it and who's not. Patients who are lost after the first encounter and never seen for the 6-month appointment will be excluded from time points of analysis thereafter. Or if they make it to the 6-month appointment and not the 12-month, then we'll just include them for the 6-month analysis. So within the first 48 hours, we'll sign the consents and everything. Like I said, we'll also do the first kind of visit. So we do a baseline neuro exam, and convert that to the pediatric stroke outcome measure. Again, I'll tell you more about these scales. We'll do our 2 developmental screeners, the developmental profile 4 and the brief 2, if they're over 5. At the 6-month visit, it's very similar. We're getting an update in their history. In between here, we're doing chart review at 6 months in person. Get an update on history, ask them how they're doing, any new medical problems, etc. We'll do another neuro exam and convert that to a pediatric stroke outcome measure. Repeat our developmental screeners so we can compare them to baseline. We'll do a social screener and assign them a pediatric cerebral performance category scale. So just an overall, how are you doing 1 through 6. Visit 3 is essentially the same thing. We did allow, even pre-COVID, we did allow the 12-month visit to be virtual. So this neuro exam and piece of the pediatric stroke outcome measure, if we don't have those, that's okay. We wanted at least one to update on their exam at the 6-month mark. If we can at 12, that's great, but if not, that's okay. Wanted to encourage, or rather discourage dropout by allowing this 12-month visit to be virtual. We'll repeat our screeners, our DP4 and brief 2, and repeat our social screen and overall scale of functioning. And then after 12 months, after all the 12 months of all the patients that are enrolled in the study, we'll compare their scores on these screenings to age-matched norms. We'll stratify groups and try to identify risk factors for who does better, who does worse. So a little more detail into these scales and things. History chart review is pretty self-explanatory, right? So we'll pay special attention, though, to any neurologic involvement documented. Neurology will have been consulted already if there were obvious things like seizures or abnormal imaging, etc. The neuro exam is pretty self-explanatory. I don't need to tell you people about the neuro exam. But the pediatric stroke outcome measure, a patient does not have to have a stroke to get to utilize this scale. It's basically, this is just the first page of it, but it tries to take your neuro exam and convert it to a number. So that you can compare more objectively how the neurologic exam from person to person. The developmental profile 4, the 4th edition of the developmental profile, assesses development in physical, adaptive, social, emotional, cognitive, and communication domains. This is very well validated and used in the kind of developmental research aspect of things, and what was recommended by our neuropsychologist. Sorry, the picture, poor quality, but this is just an example. These are yes or no questions, so I basically go through a very long list in each domain based on age of what can this child do, what can't this child do, yes or no from the parents. The brief 2 is a score of a screener looking at executive function. Again, this is validated and used in research and in clinical practice. These are questions, again, that you ask the parents, and are never, sometimes, or always. So again, it's a long list of just questions I sit down and ask parents. For example, if the patient is fidgety. Never, sometimes, always. The patient cannot find things in room or school desks. Never, sometimes, always. Looking at these aspects of executive functioning. And then a social screen tries to assess social determinants of health. This comes up in pediatric research a lot, and I assume adults as well. But there's so much research saying that patients with poor socioeconomic status do worse on development in general, or are at risk for issues with development, and if they have issues, at risk for doing poorer than age-matched peers. So while I don't know that this will give us significant changes, I thought it was important to collect this data. One, to just be another level of at least trying to point people in the right direction if they do have some of these needs, like food insecurity and things. And two, if we are seeing patterns of large swings between patients who have issues in these socioeconomic domains versus those that don't, this question will always comes up in pediatric research. So I thought, well, let's at least collect the data, and if we're seeing patterns, we can address that. And then this, as promised, the pediatric cerebral performance category is used a lot in this kind of research. It's easier to collect because you can kind of just tell knowing anything about the patient, and it's a very overall kind of score. So the higher the score, the poorer a patient is doing. 1 is normal, 6 is brain death, so 2 to 5 are kind of a range in between. 2 is mild disability as defined by conscious and alert and able to interact at age-appropriate level. But perhaps they're not at grade level for their age. Perhaps they have a mild neurologic deficit. It doesn't really define what that means. Moderate disability, again, they're conscious. They can do age-appropriate independent ADLs, but they're definitely behind in school. They're probably in special education classes and have more significant learning deficits. Severe disabilities, they're conscious, again. They're dependent on others for daily support because of impaired brain function. 5 is coma or vegetative state. Again, these are patients who are probably not at home. So 5 gets a little bit more clear. So our plan for looking at this data after every patient's 12 months is up is comparing their scores on these developmental scales to their age-matched norms. There are some age-matched norms for even the congenital heart disease population. We'll try to look at, hey, are there any patterns we can see, basically? We can group the data by age. If we have numbers, we can group data by cardiac indications versus non-cardiac indications for going on ECMO. Like that one paper I showed you that was prospective, we could group patients but with no neurologic injury versus none. One way to do that, or kind of tease that out, is maybe looking at just imaging positive versus imaging negative, like that paper I showed you. So that's one way to group things and compare them there. And then, are there any patterns we can see? Are patients with seizures versus patients who do not have seizures, or patients who had known dialysis, pulmonary hemorrhage, or other non-neuro stuff? Were those risk factors for having neurologic disease or doing poorer on these developmental screeners? So our short-term goals at this point, we're enrolling patients. Hopefully before I leave, we'll organize some of the data of the first few kind of data points that we've collected. And then I shall bequeath this project upon my successors, because as you probably realize by now, this is not going to be done in the next month and a half while I'm still here. Our hypotheses, so hypothesis number 1 is that patients who underwent an ECMO course will have some degree of developmental delay in several possible domains, including adaptive, cognitive, language, and social development, compared to similar aged peers. And our specific aim for this hypothesis is to investigate and identify the presence of long-term adaptive, cognitive, language, and social development in pediatric ICU patients placed on ECMO. Number 2, patients who underwent ECMO will have ongoing positive findings on neurologic exam as measured by the pediatric stroke outcome measure, or that kind of number that we can assign our exam. So our aim is to investigate long-term progression, recovery, and outcome of neurologic exam findings. Number 3, patients who develop neurologic injury with associated radiographic changes during their ECMO course, so these imaging positive cases, will have more severe developmental delays and increased neurologic exam changes compared to those without known neurologic injury. Number 4, patients who have known seizures during their ECMO course will have more severe developmental delays and increased neurologic exam changes compared to those without known seizure activity. And specifically, we're trying to investigate risk factors associated with long-term neurodevelopmental outcomes. So we'll compare those with known complications in ECMO course to those with known compare those without known complications or neurocomplications in ECMO course to those with known radiographic changes on imaging, seizures, significant medical complications like hemorrhage or dialysis, and an abnormal neurologic exam. So long-term goals of this study, or kind of beyond this study, are: 1, can we prove these issues exist? Again, we kind of know it, but we know these kids do worse, but can we show that they do worse? And are there any specific domains in which they do worse? I personally am really interested in executive function because I think it's something that parents have a harder time defining. Like, they'll just report like, oh, they're disorganized, or we think they have ADHD, but like, when you actually measure these things, can we say that these things exist in this population more than the general population? You know, some of that can be a lot more subtle than the kid who had an obvious stroke in his right hemiparesis. You know what I mean? Can we see what makes these issues more or less likely? And then can we alter things in the ECMO course to maximize outcomes? That's like a long-term goal. But what things can we control, if any, based on knowing maybe what places of kids at risk for doing poorer? And then, practically speaking, should we follow the kids, even the kids that don't have a known or confirmed neurologic injury? Should every one of these kids be referred for neuropsych testing? Again, this population of kids that we never meet in neurology, are we missing an opportunity for early intervention? Some of them will get it automatically because they'll have these known large deficits, these congenital heart kids that are in the hospital forever. Of course, they're going to have kind of intensive therapies and things just by the nature of their course. But these more subtle kids, do they have more subtle findings? Should we refer everyone to get people the help that they need? Should we image everybody? Again, most kids end up getting at least a CT during their course, but should everyone get an MRI? We love MRIs. You know, I want everyone in the world to have an MRI just so I can see it. But should we image all of these kids to get to screen for, again, smaller, more subtle neurologic injury that we would not see on a CT? Should all of these kids be on EEG, and if so, how long? So where are we now? We have 11 patients enrolled. 13 of them were screened. Again, 2 patients did not do it for kind of one the time they wanted to think about, and the timing didn't work out. And one again declined, but I think a language barrier was kind of an issue there. We missed at least 3 kind of in the post-holiday switchover, not on the neurology side, but again, the PICU needs to kind of tell me when someone goes on ECMO, so I can enroll within the first 48 hours. So a few were missed, but we've kind of fixed that system. 4 have died, unfortunately. This is about right. This is about 36% of the patient of 11. Although I did want to note that this is not really reflective of our institution because this is not all kids who have been on ECMO. Of the 7 remaining patients that are currently enrolled, 1 of the 6-month follow-ups have been completed. Anecdotally, just looking through his screenings last night, the patient did do worse on follow-up testing. I'm having issues with my scoring software, so I wanted to show you like the actual scores, but it's kind of, small sample size with 1. But I can tell you just looking at things that he did do worse. 2 more are due for their 6-month follow-ups, which are in process now and scheduled. And the remainder of the currently enrolled patients, of course, will be due for their first follow-up, their 6-month follow-up in the coming months. Kind of what's next for this project. So the U of L contingent of this project is being taken over by Dr. Max Gallivan, Dr. Aaron McCoy, and Dr. Keerthana Bathala. Those are some of our, Dr. Gallivan and Dr. McCoy are finishing up their PGY2 year and coming to the neuro side, the good side, in July. So Max and Aaron, look out for them. And Keerthana, Dr. Bathala, she's a current PGY1 that will be going to PGY2. So I have kind of a line of successors, because this will likely take about 4 years at least in total to get appropriate numbers. Our goal is 50 patients. We'll continue enrolling patients, and then I hope to make this a multi-center study. I've accepted a faculty position over at University of Kentucky, and actually already have a person in their ICU who's interested in helping me get this basically the same study off the ground. It would be smaller numbers, but they do ECMO there, so that would be amazing to have this be a multi-center study, and that would hopefully get us at least to some help in numbers to get there more quickly. That's it. That's all I have. If anyone has any questions or comments or thoughts, I'd love to hear them. Okay. Well, thanks everybody for listening. If you're on the pediatric side and know of a patient on ECMO, let me know. I don't want anyone to get missed. But have a great day, everybody.
Thank you, Anna. Thank you so much.
Thank you, Anna.